Excuse me, everyone. Thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your line is in a listen-only mode. At the conclusion of the presenter's presentation, we will open the floor for questions. At that time, instructions will be given as procedures to follow if you would like to ask a question. I would now like to turn the conference over to Joseph Betancourt. Sir, you may begin.
Good afternoon, everyone. My name is Joseph Betancourt, and I'm the director of the Disparities Solutions Center in a very snowy Massachusetts General Hospital. I want to welcome you today to our web seminar entitled Tools for Measuring and Monitoring Equity and Quality, the Hospital Perspective. This program is the first in a pair of web seminars sponsored by the Health Research and Educational Trust of the American Hospital Association and the Disparities Solutions Center. Health Research and Educational Trust is the not-for-profit research and education affiliate of the American Hospital Association. Its mission is to transform healthcare through research and education. Among various activities, HRAT leads hospitals in pursuit of excellence, the American Hospital Association's strategic platform for accelerating performance improvement and delivery system transformation. This platform includes a growing agenda of activities related to healthcare equity. The Disparities Solutions Center is dedicated to the development and implementation of strategies that advance policy and practice to eliminate racial and ethnic disparities in healthcare. And I will be moderating today's panel of speakers. And I just want to reiterate, we're very excited about this new collaboration between the Disparities Solutions Center, HRET, and the American Hospital Association. A decision by hospitals to collect race, ethnicity, and language data invites an array of new issues and choices. In this webinar, our panel of experts will answer questions about moving forward with data collection and reporting quality measures by race, ethnicity, and language. In particular, this discussion will focus on how this is related to measuring the patient experience and patient satisfaction, as well as the use of internal and external disparities dashboards to measure and report outcomes. That brings us to today's web seminar. We are pleased to be joined by Susanna Rinderly from the University of New Mexico Hospitals, Sarah Rafton from Seattle Children's Hospital, and Dr. James Walton from Baylor Healthcare Systems. Each of these organizations are alumni of the Disparities Solutions Center's Disparities Leadership Program, a year-long executive leadership program designed for leaders from hospitals, health plans, and other healthcare organizations who wish to implement practical strategies to identify and address racial and ethnic disparities in healthcare, particularly through quality improvement. We will be taking questions from the audience throughout today's presentation. You can submit questions by typing them in the chat box at the lower left-hand corner of your screen, making sure that you specify to whom the question is directed, if anyone in particular, and hit Submit Question. I'll be leading the audience question and answer session during the last 25 minutes or so of this web seminar. I want to also let you know that an archive of today's web seminar will be available on our website after 2 weeks. Our websites are www.mghdisparitiessolutions, all one word, .org, and www.hpoe.org. So now let's turn to today's topic, Tools for Measuring and Monitoring Equity and Quality, the Hospital Perspective. I want to go ahead and begin by more formally introducing our three presenters. As I mentioned, and their bios will be here in their entirety. If you take a moment to read them, I'll just be summarizing them briefly. We have the good fortune of having us join the group today, Susanna Rinderly, who is the Manager of Diversity, Equity, and Inclusion at the University of New Mexico. Again, on your screen, you should be able to see Susanna's full bio. A qualified and trained dual-role interpreter for UNMH, Susanna spearheaded the creation of the Health Literacy Task Force at UNMH, which she now chairs, and wrote the original Diversity and Inclusion Plan. In October, she became the first Manager of Diversity, Equity, and Inclusion for UNM Hospitals. Susanna, thank you so much for joining us, and welcome. Next, we have Sarah Rafton. Sarah Rafton is the Director of the Center for Diversity and Health Equity at Seattle Children's Hospital. She's been instrumental in forming the Center for Diversity and Health Equity and leading quality improvement efforts to assure interpreted care for families with limited English proficiency. In addition, she established the hospital's Patient Navigator program. Sarah, thanks so much for joining us. And finally, we have Dr. James Walton. Jim Walton, who is the Vice President and Chief Health Equity Officer of Baylor Healthcare System in Dallas. In this role, he is charged with overseeing healthcare equity improvement throughout the system and ambulatory care centers through Health Texas Provider Network, Baylor's physician group. He also chairs the BHCS Health Equity Advisory Council. Again, I'd like to thank all speakers for joining us today, and thanks, Jim, and welcome. By way of background, I want to begin this session by just highlighting the fact that we consider Crossing the Quality Chasm one of the preeminent documents as it relates to improving the nation's quality of healthcare. As many of you know, there are 6 key pillars that undergird quality in this nation, and they include healthcare being safe and free from medical errors, effective, using the best evidence possible, patient-centered, responsive to the needs, values, and perspectives of patients, timely. The patient should receive things in a timely fashion and not have to wait inordinate times for procedures. Efficient and not being wasteful of resources, and finally equitable, that there should be no variation in healthcare quality by any personal characteristics that include race, ethnicity, gender, or others. As we embark on this journey, we think about the steps towards achieving equity in quality. And really there are 4, and you could follow this from the top left-hand corner going clockwise around. First, and probably the most important foundation of this work, is the collection of race, ethnicity, and language data. Next is using this data and linking it to the quality metrics to develop reports and develop the capacity to identify and report disparities in care. Next, we think about identifying, once we've identified disparities, implementing solutions to eliminate them. And then finally, in the last quadrant, evaluating the effectiveness of these solutions and going through the process once again. Strategic planning really is at the center of this work. And our talk today will focus on the second quadrant, which is identifying and reporting disparities in care. I'll mention that we here at Mass General have had the very good fortune of developing a disparities dashboard ourselves in about 2006. And just wanted to highlight some of the key points before I turn this over to my colleagues and let them share some of their experiences as well. We, through work with the mayor of Boston as well as through our quality and safety leadership, developed our first disparities dashboard several years back. It is a yearly dashboard that goes out to about 500 leaders throughout the organization. And I just wanted to highlight a couple of key aspects of it. First, we, as part of our dashboard, provide a welcome and purpose where we define what disparities are and really describe how we're going to focus on disparities in health care. We next talk about the purpose of the dashboard, that it will be released annually and that really this work is embedded into our quality and safety reporting. We then explain how our data and measurement tools are collected, for example, how we collect race and ethnicity, the process, the categories, as well as the data sources, and there's a list here that we use to put together our dashboard. Finally, we create a snapshot of the diversity of MGH patients, for example, who they are and where they are seen. And so from this, we know, for example, that we see most of our minority patients in our pediatrics and OBGYN services, in our emergency room, and as well as in several of our community health centers. As it relates to clinical indicators and measures, we began very early on by stratifying our national hospital core measures: acute myocardial infarction, congestive heart failure, community-acquired pneumonia, and surgical infection prophylaxis, as well as stratifying our outpatient measures, HEDIS measures, in mammogram, PAP, colorectal cancer screening, diabetes measures, and coronary artery disease measures as well. We also began to look at physician and practice linkage, trying to identify by race and ethnicity which patients were linked to a practice, to a particular physician, or unlinked, meaning that they saw us sporadically. This is a way to identify whether we see disparities in linkage to a physician or practice. And this is important because we know that the closer a patient is linked to a particular primary care provider, the higher their quality is regardless of race, ethnicity. So we're tracking this and trying to make innovations in that area. Finally, we're looking at patient experiences with care. Initially, we began stratifying our Press-Ganey inpatient satisfaction by race, ethnicity, as well as looking at our results of quality and safety rounds where we incorporated disparities questions and also developed a particular specific survey of minority patients on their experience at our hospital. And we also look at how many interpreter visits we do a year, and that's the last component here, communication with LEP patients. Over the course of the last year, we developed several innovations as part of our dashboard. As we've moved from Press-Ganey to HCAHPS, we are now stratifying our HCAHPS by race, ethnicity, and looking at subgroups as well. In anticipation of healthcare reform and payment reform, we've begun to stratify our all-cause and ambulatory care sensitive admissions by race, ethnicity, as well as our congestive heart failure readmissions by race and ethnicity. In an effort to really go beyond just the measures that are out there and available and stratifying them by race, we are creating several measures that we call sentinel measures, areas where we know there are disparities in the literature, and we're developing measures to see if we have those disparities here on campus. And those include mental health and the treatment of depression, pain management in the emergency room, particularly of long bone fractures, wait time for renal transplantation, and orbit time for bypass surgery. And as you'll see in just a few seconds, we report all this information externally via our Mass General Hospital Quality and Safety website. I'll just share with you here what our executive summary looks like. We break our outcomes up into 3 areas: green light, orange light, and red light. Green light are areas where care is equitable. For example, we've seen no disparities in our national hospital quality measures, our HEDIS outpatient measures on the main campus, as well as pain management in the emergency room. We have several areas that are orange light, areas where we see disparities nationally, and areas that we are exploring, as I mentioned: mental health, renal transplantation, all-cause and ambulatory care-sensitive admissions, so far no disparities; congestive heart failure readmissions, so far no disparities; and HCAHPS patient experience, and we're exploring some of the differences that we've seen there. Finally, we identify several areas where we have found disparities and have developed interventions to address them, and those are our red light areas. And they include diabetes at two of our community health centers in Chelsea with Latino patients. We've seen poor control of diabetes among our Latino patients, as well as poor control among our Cambodian patients in one of our other community health centers in Revere, as well as differences in colon cancer screening, colonoscopy screening rates, particularly Latinos getting less colonoscopy than their white counterparts at one of our health centers. A long way of saying that in the areas where we've identified red lights, we've developed programs that include coaching programs, navigator programs to better address these disparities. To conclude, as I mentioned, we have all this information available publicly. People can go ahead and Google MGH Quality and Safety, and they can see our external disparities dashboard here with some of our measures, as well as background story on some of our interventions. So we're very excited about this work, and we've been even more excited that we can share this work and learn from and learn with some of our colleagues who are on our call today. And that leads us to our first presenter, who will share the incredible work that's being done at the University of New Mexico hospitals. So I would now like to introduce Susanna to get us started. Susanna, welcome to our web seminar. Thank you so much for joining us. And let me ask you to go ahead and begin and give us a quick overview of the University of New Mexico hospitals, and particularly its Office of Diversity, Equity, and Inclusion.
Thank you, Joe, for the kind introduction, and I'm delighted and honored to be a part of this panel this afternoon. And what I'm going to do real briefly is give you folks some sense of our organization and then the context in which we're doing our data collection and analysis work. So just to sort of break down the entity that is UNM Hospitals, we're the only public and only teaching hospital of note in New Mexico, and one of only 30 hospitals nationwide that serve both roles. We're the only level 1 trauma center in the region, and when I say region, folks have to go to Lubbock, Texas, Denver, or Phoenix to receive the type of emergency services that we have here in Albuquerque. We have the only emergency adult psychiatric services, and we're about a 619-bed hospital that includes 5 different hospitals and 48 clinics, 22 of which are off-site. And we're adding about another clinic or 2 every year at this rate. Our payer mix, like my other colleagues on the call, we have a large percentage of folks that are Medicare or Medicaid patients, and about 17.3% of our folks are uncompensated. We've got about 6,000 employees, and about 500,000 outpatient days, and a budget of around $700 million. So in terms of our wider context, for those of you that aren't as familiar with the uniqueness of our particular region of the country, we have a very small population, so there's about 2 million folks in the entire state of New Mexico. I'm originally from Los Angeles, and that's about the size of one neighborhood. So it's very different in terms of our distribution, and we are the 4th highest percentage of frontier lands, and that's a designation that has to do with population distribution. The others before us are Alaska, Texas, and Montana. We're one of only 2 states in the U.S. that have always been majority-minority, the other one being Hawaii. What I mean by majority-minority, I mean majority non-white. We're the only majority Hispanic state, contrary to popular belief. We're at about 45.6% as of last year, and that's just ahead of California and Texas. We have the second highest percentage of Native Americans. The first would be Alaska. And then what's especially striking, I think, is that given that we are a state of such sparse population, we also have the fifth highest total number of Native Americans. We rank after California in terms of being the state with the second highest percentage of residents that speak a language other than English at home. But if you phrase it in terms of households that speak something other than English only, we're actually at 60%. So a high number of languages other than English or languages being spoken in combination with English. So we have a very long and proud history with regards to language access. We have had our own in-house interpretation department since 2003. 16% of our patients, and that's held steady now for some years, are LEP or Limited English Proficient. Currently, we have 18 full-time interpreters in our three major languages, Spanish, Vietnamese, and Navajo, and some additional administrative staff. Apart from that, we have approximately 130-plus dual-role interpreters, so those are folks that hold other jobs and are tested, trained, and qualified as interpreters on the side. I would be one of those folks, at close to 10 languages. And we also do interpretation through video units, and we have access also through our 24-hour phone line. Other things that were key along our journey with regards to health equity are our participation, as Dr. Betancourt mentioned earlier, in the Disparities Leadership Program, and then my office being created in October. So my office is the Office of Diversity, Equity, and Inclusion, and my mission statement is that we lead the effort to make sure that every UNM hospital's patient receives the safest, most effective, and most sensitive medical care possible, regardless of the patient's race, ethnicity, or any other group identity. And our four main areas are data collection and analysis, community collaboration, cultural competence training, education, and consulting and process improvement.
Susanna, that's an ambitious mission statement and a tall order. What do you have in place to ensure that you're able to accomplish these things?
Well, we have a structure which is available on our website for folks to peruse in more detail. We have our executive steering committee, which is comprised of top leadership. And then we have what I call our 4C task forces, so compliance, community, competence, and care. You'll see the three rectangles in green are the bodies that are live at this point. And we've been spending most of our time, as you can see, the compliance task force was established in November of 2009, really gathering data, numbers and quantitative data as well as qualitative data from our community and from the experience that we've had with our patients over time to determine where we're going to go next. I'm sure very few folks on the call today will need a reminder of this, but we find this particular graphic very helpful in sort of making the case that this is not something extracurricular, that addressing disparities and increasing health equity is about increasing and improving patient safety, quality of care, and it's just a continuous feedback loop. A couple other tools I want to just share real briefly with folks that are, again, available on our website that have helped us on our journey are this comprehensive self-assessment document that we took, and I'll show you the cross map, which is a little bit easier to understand. And much like Massachusetts General, we use a color-coded system of red, yellow, and green. And basically what this is it took all of the major documents that have issued either requirements or recommendations on healthcare disparities, specifically the class standards, the Joint Commission, the National Quality Forum, the National Association of Public Hospitals in our case, and then NCQA, and sort of combined those together, created some new headings that are then assigned to one of our 5 bodies. I want to add also that we will be doing an extensive organizational self-assessment with regards to health literacy in the coming months. And we're also going to be looking very carefully at the Joint Commission's excellent roadmap for hospitals document that really is very detailed in terms of helping hospitals move forward with regards to their recommendations for 2012.
That's wonderful, very complex and certainly detail-oriented. What data are you collecting to monitor your progress right now?
Well, Joe, we're very much in the initial stages at this point. We have these 5 items that you folks can see on your screen that we started in 2010. I really am a big believer in acronyms. It helps people remember things. It helps with the communication. And so we've dubbed this REALS data: race, ethnicity, age, language, and sex. Those are required to be, well, we've been collecting some data for some time, which I'll talk about in a minute. But what we're especially proud of is that as of July of 2010, all of our departments and units are required to put their REALS data analysis of their patient demographics in their operational plans. Our operational plans are business plans that each department and unit have to create annually. And so for the first time, folks are required to put in the demographics of their patient population, which really began to raise some awareness and encourage and inspire positive questions. I mentioned that I would say how we're collecting our data. We are a 100% electronic medical record organization. We have a form, which I'll show you on a following slide, that we present to our outpatient patients that they fill out themselves, and that those data are then entered into the electronic medical record by staff. That's been going on since mid-2008. And in our inpatient units, we have collected data on patients upon admission for some time, but we started to use the same form with inpatient after we rolled out the form in outpatient. And I already mentioned about the operational plan. This is the form that we use to collect our data. Currently, we are in the process of making some edits as we speak to what we are collecting and how we're collecting. Those of you that are familiar with the recommendations coming out will notice that we have race and ethnicity combined, and that's one of the things that we are going to be changing. So in terms of our changes, we are going to break out race and ethnicity. We have hopes to start collecting sexual orientation and transgender status on our patients. The LGBT community is one of the communities that suffers some of the worst treatment and disparities. The Lambda Legal report details that pretty nicely with a lot of data. And so we're exploring that very seriously, and then collecting not just oral language preference, but written language as well, and also doing that for the parents of PEDS patients. The initial indicators that we are tracking are these that you see on your screen. We are actually in the process of finalizing those now. In fact, I have a meeting in a few hours in which we're going to re-examine and finalize these. Much like Massachusetts General, we likely are going to add a couple other core measures. But as you can see, we have several clinical indicators as well as non-clinical indicators that we're going to be tracking. We're not quite sure yet whether we're going to do childhood immunization or PEDS asthma. We're not quite sure what type of colorectal cancer screening indicator we're going to track yet. And also the survey at the bottom there, the self-reported employee and provider awareness attitudes, belief, and those types of things are going to be coming in the next month or so. So just to show you folks some very preliminary data that we have, we went back and we looked at our, we use Press Ganey for our customer as well as employee satisfaction survey vendor. And we went and we looked at our Spanish language surveys. So we survey our patients in English, Spanish, and Vietnamese. And I looked at all of our LEP Spanish language Press Ganey surveys that have come back since 2006 to see if we could identify any trends with regards to any interventions that we were doing. And two things you'll notice here right away are an upward trend as well as some stabilization in 2010. Now, we don't quite know what that spike is, and we're still looking to see if we can identify what that was caused by. And you'll notice we have both outpatient and inpatient here. What I can tell you is that sort of this larger upward trend that was preceded by a downward trend was due to several things that we implemented during January to October of 2009. We consolidated the way that folks communicate with our interpreter services, our various interpreter services, whether in-house or external, to one phone number, which is called 2Talk, and stickers were placed on phones across the organization. We implemented the VIP, those are our video units. We hired an interpreter language services educator who is also a dual role interpreter and very passionate and knowledgeable. We had a vehicle available for our off-site interpreters to be able to get to the sites more quickly. We put phone splitters in the clinics so that the registration frontline person and the patient could both hear the interpreter on the phone line more easily. We did a couple different publicity campaigns using booths, using various written materials, and we think that's the reason for the slight drop-off as sort of the change rolled out, and yet the increase and then the leveling off in terms of our patient satisfaction. In addition to that, we looked at our return rate. You'll notice that we had a tremendous spike that happened here in 2007 with our outpatient. And the reason for that is that we lobbied quite heavily to get the budget increased. So previously we were surveying about 6.69 of our outpatient patients. That's randomly sampled, and that random sample includes languages other than English, so we don't separately sample our non-English patients. And so we were able to increase that percentage to 16.67 and increase our monthly max from 1,800 to 4,550. We also did an extensive campaign in our clinics for discharge folks in terms of training them about telling the patients, the primary Spanish-speaking patients, about the survey, showing them a copy, encouraging them to send it back, and helping them understand why that was important. That was only done in outpatient, so you can see that we had some real results from that intervention. We're still trying to figure out what the dip was last year, but we're very excited about the promise of the campaign that showed in the previous year. Just to sort of finish up, this is a very, very initial snapshot of parts of what is going to be our first equity dashboard. So again, this is very much a draft. Even leaders in our organization haven't quite seen this yet. So as I mentioned, we're still even clarifying our indicators. But we're using the same format that our organization uses for other dashboards, and going to be breaking out our various indicators by the reals or the reals data, as well as showing trends over time. Those are just a couple snapshots of our discharges, demographics, our mortality, and our average length of stay, which are 3 of our initial indicators. So where we're going next is to make some modifications to both our intake form as well as our systems with regards to the exact data that we're collecting and how. We've got some requirements from our local New Mexico Department of Health we have to be compliant with in terms of changing the wording of some of our tribal information that we collect from our Native American patients. We're particularly struggling with the multiracial category. There seems to be a little bit of contradiction or not quite overlap in terms of how the various bodies are asking us to collect that. And we are a very multiracial, multi-ethnic state with a very large percentage of others traditionally, so we're exploring creative ways to address that. And just really getting our dashboard up and running and the analysis of our initial findings, which will then drive my strategic plan and recommendations that will then build our competence and care task forces. And then from that, rolling out unit-specific as well as organization-wide interventions. So that's our plan for UNM hospitals, and thank you.
Wonderful. Thank you so much, Susanna. It's a great presentation. And I'm prompted here to ask people if they have questions, but we already have about a dozen questions for you that hopefully we'll get to at the end of the presentation. If anybody has additional questions for Susanna, please use the chat box on your screen, hit Submit Question, and again, we'll be holding questions until the last 25 minutes when we'll have our Q&A. But thanks again, and I think you've generated a lot of interesting questions and discussion already. So now we're going to move on to our next speaker, Sarah Rafton. Sarah, I'm going to turn to you now. Sarah's from Seattle Children's Hospitals, as I mentioned. Sarah, welcome to our web seminar. And let's begin with a kind of a profile of where you are and the racial and ethnic diversity you serve in your region.
Thank you, Joe. I want to orient you to Seattle Children's. Like UNM, we're a safety net hospital, and about half the patients we serve are on state and federal-funded health insurance. And we provide now about $100 million a year in uncompensated care to the children and families that we serve. We do have a culture of continuous performance improvement in our institution, and I wanted to let you know that because I think it has lent itself to people being very open and accepting of hearing data about how they can do their job better. Our culture is very much about that in the institution, and it's made our work at the Center for Diversity and Health Equity quite a bit easier. So we do serve a 4-state region in the northwest of the U.S., and so children travel great distances to receive care at Seattle Children's, their specialty care at Seattle Children's. When we look at our race of our patients served in the most recent fiscal year, at least 35% of our patients are non-white or Latino. And we look at ethnicity, 15% of our patients are Hispanic or Latino. And I want to point out that that's actually much more diversity than in the city or county in which we're located, because we do serve children who are coming from more agricultural regions of our state, north of our county, and in central and eastern Washington. And so those in those areas, there are a higher proportion of Hispanic and Latino families. We serve about 16% of our patients. Parents have limited English proficiency. When you look at the diversity of our languages, Spanish is far and away the largest language that we serve, followed by Somali, Vietnamese, and Russian. But Seattle is a refugee resettlement site, so we also have tremendous language diversity after those top languages.
Fantastic. That's a wonderful background. How is it that your hospital has come to form a center? And tell me a little about your center's role in the organization, Sarah.
Our hospital became aware of disparities in families' experience at the hospital. We conducted multiple focus groups, homogeneous by race, ethnicity, or language, and heard from families what their experiences were at the hospital. And the hospital is also aware of disparities in family satisfaction from our family satisfaction survey. And in addition to that, there was a study conducted at our hospital that determined that Spanish speakers were at twofold risk for adverse events while hospitalized. The hospital saw this as an opportunity to assure the highest quality of care for all our patients and to stand apart in the country for our quality of care. So we formed in 2007, and we have, I have to say, our senior administration at the hospital is just uniquely supportive of what we're doing and very aware of the importance of equity, pretty passionate about it. So we report directly to the president and COO. We now have 6.5 staff that are supported by hospital dollars and 1.5 staff that are supported by external funding. And we have some terrific oversight and support for our work. So we have an internal, pretty tactical steering committee that includes some of our champions inside the organization. I have to say it's not just our center that's doing this work, but our marketing department, tremendous advocates, as well as the Department of Pediatrics and our advocacy department at the hospital. So our internal oversight includes those folks. And then we have an external and internal advisory group that's much larger, and it includes community champions, including our state health officer and community physicians who have great background and knowledge in disparities and inequity. Our department has a 3-part function. So we partner with people across the hospital to accomplish this work. The work falls in the areas of safe and effective care for all patients, community outreach and engagement, and improving the diversity of our workforce to reflect the patients that we serve, and improving the competencies of our workforce as well. During the time in our talk today, I'll be focusing on safe and effective care for patients. I want to share with you, you heard from Joe the importance of collecting accurate race and ethnicity data, and I just want to reinforce that. It's not always the most exciting place to start this work, but you really must do this work. So we started in 2006 using the HRET toolkit, and we used the Office of Management and Budget race and ethnicity categories. And what we have done is partner with our registration staff, and I can't tell you how important they are to our success, and we've cultivated a really strong relationship with them. We're in front of the registration staff at least 3 times a year, if not more than that. So initially, of course, that focus was on how to gather the data. But then once they were up and running gathering the data, we've created a safe place for them to share experiences and express their struggles collecting the data. And we also share with them how we use the data. So we share with them the ways that we're measuring equity at the hospital. We also share with them what cultural competency means. Their continuing education includes viewing unnatural causes, and we've provided them sessions on experiences working with Latino families and Somali families. They are just tremendous champions for our work. And they've expressed to us the work we do together is one of the first times they've felt they've been asked to collect data in which people keep coming back to them. And you know, if you ever observe a registration staff, the volume of work they're handling is really incredible, and they're continuously asked to gather more information. And they said that our ongoing relationship has made them feel very valued. They also have within their department, we really rely on this, they have a quality assurance staff person within their department. So on a monthly basis, they are looking at how good their rates of collection are, and this sort of never stops. So again, we started in 2006, and we're doing QA every month to date. So the accuracy of our collection is really terrific as a result of their hard work.
And that's really essential. An essential background, I think, and foundation for this work. What was your initial application of equity to hospital goals and metrics? So how did you make that connection?
We initially looked at we used the NRC Picker Family Experience Survey, and unlike Susanna's slides, I want to point out on these slides, higher is worse, so lower is better. So we looked at our Family Experience Survey and looked at a variety. There are 60 questions on the survey, and we looked at where did disparities lie. And in our inpatient setting, we see pretty significant disparities in families reporting that they wanted more involvement in decision-making about their children's care while they have an inpatient stay. So you see about 30% of whites wanted more involvement, and in the previous year, about 60% of non-whites wanted more involvement, and a vast majority of Spanish speakers, at about 80%, wanted more involvement. In this past year, we've seen some improvements with just less than half of non-whites wanting more involvement, and a little closer to half of Spanish speakers wanting more involvement. We speculate that this could be the high rates of interpretation we're providing. We're providing on average now 2 interpretations per day during inpatient hospitalization via phone and in person. We have in the past few years, certainly since 2008, we have oversampled our Latino and non-white populations, which has now resulted in a response rate that is proportional to our patient population. So having that support, Susanna also mentioned that, having that support to get adequate response rates from diverse populations is really important. In the outpatient setting, the biggest disparity that we saw is families leaving with important questions on their mind that they didn't ask, things they knew they wanted to ask and didn't ask. And you see about 10% of whites, that is the case, about 20% of non-whites, and over 30% of Spanish speakers. See a little bit of improvement here in these past few years, and we have had a focus on encouraging families to ask their questions in the past few years, and we're hoping that is making a difference.
Yeah, it's critically important, particularly as it relates to medication adherence or knowing when to follow up, knowing when to seek more acute care. Fantastic. What has been the value of measuring equity in patient satisfaction?
Well, this is actually formally included in our hospital's quality dashboard. So it's out there for everyone to see in the organization, and people can pull up how their unit is performing. So we've really, by having that embedded in our hospital's dashboard, we've raised awareness amongst our staff and faculty. And we also, I will say this is one of the ways that the hospital said, wow, we really have to do something about equity. Our leadership and our board of trustees is incredibly invested in families' experience at the hospital, and that has helped us dedicate some resources to try and improve that experience. And as well, presenting this data to our staff and faculty has them, as I mentioned, our culture of continuous improvement. It has people saying, how can I do this? How can I better partner with families across culture? And we have really strong interest in doing so. So I think we've raised awareness of the need to alter practice and tailor practice to each family with whom you work.
And when you think about limitations of measuring equity and patient satisfaction, what types of things come to mind?
Well, this is a mailed home survey. It's long. I worry about the education level of our patients completing the survey. I also worry about families at low-income levels moving frequently. It's also not a quality improvement tool. This is not sensitive to be looking at on a monthly basis and say, oh, what did we do differently this month, or really even this quarter. I think it's worthwhile to look at in trends over a year, but it's really not a QI tool, and there's a lot of desire within our organization for it to be that. As well, we have pulled out our hospital. The way a hospital uses a survey is they pull out individual questions and look at how we're doing on individual questions. But NRC Picker designed this survey to be validated using domains, using dimensions of care, which are many questions rolling into a domain of care such as access, partnership, or continuity. So by pulling out those individual questions, I think we lose a little bit of the validity of the tool.
You mentioned here interventions, and as you think about interventions, what types of things have you implemented to try to decrease these disparities in satisfaction that you've identified?
We do have a pilot patient navigator program where we have culturally congruent patient navigators who are certified interpreters partner with immigrant parents to teach them how to use the healthcare system. They serve families whose children have chronic and complex pediatric disease, and they really teach parents to participate in their care. And the program, once they teach parents how to navigate and participate in care, then we graduate families out of the program. By doing this, we do see some improvements in satisfaction. You see that that for families, English-speaking families without a navigator, over 20% were dissatisfied with their access to care, and 25% of Spanish speakers without a navigator were dissatisfied with access. But 15% of the families who had a navigator reported dissatisfaction with access. And again, you see much stronger partnership with clinicians, with between 5 and 10% of families without navigators being dissatisfied with their partnership, but only 2% of families who had a navigator were dissatisfied with partnership with their clinicians. And in the area of continuity, we see higher satisfaction for patients with navigators. Between 10 and 15% of patients without navigators were dissatisfied with continuity of care, with only 2% of patients with navigators.
That's very interesting. So, if you reflect back on the quadrants that I put forward, you guys have collected race ethnicity data, you've monitored, you've developed interventions, and now you've evaluated them, which is, I think, really the model that we're aspiring to. How are you moving beyond patient satisfaction, and how have you decided what else to measure?
We are measuring we've measured a few things, and I want to point out that these are not yet embedded into the hospital's dashboard, but we're sharing this data with key stakeholders and partnering with key stakeholders to evaluate this data at the hospital. We've looked at bloodstream infections, which of course is incredibly important safety metric for all hospitals. We've looked at time to the emergency department physician because we've seen non-whites and Latinos more dissatisfied with their weights. And we've also looked at pain management. There's obviously very well-known disparities in the adult literature for pain management, and it's a hospital value to have consistent pain management. But as well, we had a faculty champion who really wanted to help us with this measurement.
Yeah, very important, and I think really critical. Who do you partner with within the hospital to measure these outcomes?
Well, for example, on bloodstream infections, we partnered with the nurse director of infection control, the physician who oversees infectious disease, and the senior vice president and chief nursing officer. And what I want to point out in the webinar today is that you can initially assess for a disparity, but you have to dig deeper with the people who really understand the content area in which you're working to get to the heart of the matter and determine if you really do have a disparity or not. So when we looked at BSIs initially, we saw that Latino rates for BSIs were higher than the Latino proportion at our hospital. But as we dug down deeper, we looked at specific oncology diagnoses that are at high risk for BSIs, and we saw that those particular diagnoses have a higher portion of Latinos with those diagnoses. So in fact, what we initially thought was a disparity was not. And we are now moving to do a similar evaluation for our chronic dialysis patients.
That's great. You've definitely taken on a very important safety metric to all hospitals and bloodstream infections. What have you learned about timeliness so far?
This is pretty exciting for our emergency department to see. They're very focused on getting patients seen by their physician as soon as possible, and you can see that patients who are admitted to the hospital across language, race, and ethnicity, we really see almost no difference in the time to physician if you were admitted to the hospital. And for patients who were discharged to home from the emergency department, we see very little difference as well in their time to physician. We did observe for Russian speakers who were admitted for urgent or emergent reasons, a little bit of a difference, but our medical leadership in the emergency department believes this is not a significant difference. And then in our most serious cases, we found some differences for our limited English proficient families, but it was just 3 cases. We have done an initial review of these cases and have found that 2 of the children received care the moment they walked in the door, and 1 child was treated within 5 or 10 minutes. So we're doing a more thorough evaluation for that 1 child, but largely we're just not seeing a difference, and the emergency department is so proud of their time to physician that now they can be proud of the equity in that metric as well.
Great. Well, let's close it out with pain management. How about your pain metrics?
Yeah, we partnered with an assistant professor in anesthesia, and we chose to measure a hospital standard of care for pain metric. And I would just encourage people who want to do this work to find faculty champions within your organization who care about equity. And we have found that we're providing equitable care in assessing pain, and it's looking like in treating pain as well. But we're going to increase the N size to further evaluate that. And I just want to say that some of our next steps include embedding equity into the hospital dashboard. The BSI work I shared with you, that was a project we did, but if you pulled up our dashboard, you don't see equity for BSIs in there yet. Core measures of asthma care, for example, you don't see equity there. So we want these clinical and safety metrics to include race, ethnicity, and language, and not have the Center for Diversity and Health Equity be the people measuring it, but have the hospital be the people measuring it.
Great. Well, thank you so much for your insightful perspectives. Really interesting. I think you've shown us how to kind of, again, go from collecting data to linking it to quality to then, really, as you mentioned, digging deeper, not just kind of taking the first slice, digging deeper at some of the issues and developing interventions to address them. So we have a lot of questions coming in. Please keep them coming. In the chat box, submit question, and we'll get to those questions very shortly. And last but certainly not least, I want to turn our web seminar over to our final speaker, Jim Walton from Baylor Healthcare System. Jim, welcome to our web seminar. We look forward to your comments, and we're going to turn over the presentation and the floor to you.
Thank you, Joe. It's a pleasure to be here. Good afternoon, everybody. Just to give you a real brief thumbnail of the Baylor Healthcare System, we're situated in the Dallas-Fort Worth metropolitan area, and affectionately known as North Texas. They're going to have a big game here next week. We currently have about 24 owned or leased or affiliated hospitals connected to our system. A fairly large footprint across the metropolitan area with 120 primary care, specialty care, and senior health centers. 17 ambulatory surgery suites, and over 450 docs that are employed, 20,000 employees, and so in a rather large operating revenue. So our footprint is very large, and so the work of health equity, while new to the quality work of Baylor, is slowly but surely getting a foothold in the organization of this size.
Great, Jim. As you think about these demographics, any demographic considerations that you consider in your daily work? Does the community composition affect the information you seek?
We've been, of course, we have such a broad geography. Each hospital, as you might guess, has its own unique demographic footprint. So we do have to make some general concepts. So my work has been, over the last few years, just trying to get some buy-in to the concepts of disparities in health equity. And so as you can see in the next slide, that what we've taken a shot at here is that we looked at the population cuts by race that is collected by the census in the region for our market region, and then looked at also what happens to a handful of our hospitals with regard to the inpatient size. And so what we're again illustrating in this slide is just that there is some slight differences between what the population demography looks like and the percent number of people of those groups, and then how do we serve those groups. In the next slide, you'd see that same kind of analysis by ethnicity. So what we're aware of is that we can also look at this, and we have in our relative to our emergency department, and what we see over and over again is that we're serving people that are experiencing health disparities, typically people of color, in our market are typically getting most of the care in the emergency department. So that we're using this kind of analysis to help prompt our organization to start to think about health equity and health disparities.
Tell us a little bit, Jim, about the Office of Health Equity.
So we were developed about 4 years ago, and our goals, as just like the others in the that you've heard today, is really to reduce variation in healthcare access, care delivery, and health outcomes by particular personal characteristics. The next slide, we would show that our goals, first and foremost for us, is to kind of stimulate the organization at the individual operating unit level to really care about this. And so one of the big tasks that we've been working on for the last 4 years has been to create an effective health equity performance analysis and report that can then sit on our intranet so that folks around the organization can actually see that as part of our quality report. And we're happy to say we've recently been successful at achieving that goal and are now starting to gain some traction and starting to work on that. So as you can see, we have quality of care measures that kind of are, we use core measures as proxies for that, and we use satisfaction as a proxy for experience of care, and then mortality and readmissions as an outcome measure. Now this is the inpatient side, and we have something just starting on the ambulatory patient side as well in our outpatient clinics. So as we do this analysis, just like most of the folks that you've heard, we break the patient population down. Now we collect the data through access services, just like at registration, just like has been spoken of earlier. But in our particular type of analysis, we use dichotomous variables: race is white versus non-white, ethnicity, Hispanic versus non-Hispanic, and then as an SES proxy, we use commercially insured juxtaposed to self-pay and Medicaid for income status. Then we actually test that percent differences between the dichotomous variables to see if there is a statistically significant non-random difference between the data elements that we see, so that when we stand up and say that there's a consistent delta between these groups, then we have a fairly good, strong standing that it's not a random chance.
Great, Jim. And I see these are not OMB defined categories, and that's actually one of the questions that people have raised. You want to make a quick comment about that?
Basically, this is a strategic political decision on our part. We collect the data based on OMB recommendations because we have, that's a law, that's part of the law. But when we analyze the data, we aggregate it into these groups, basically for the ease of the audience to understand. We looked at the data originally with all the different breakouts between different races and different ethnicities, and it was very noisy. The slides were very noisy, and sometimes in some quarters the ends would be pretty low, and we would see a lot of variation. So we smoothed out the curves, and it looks a lot more attractive. And it's interesting, we've gotten a lot more political traction with using just big groups to kind of sell the story.
I'll just add too, Jim, that we've done the same here. Areas where we have smaller cell sizes, we've kind of done that roll up as well.
Yeah. So the next slide, I think, is a sample of our dashboard for the audience, just to show you in a little blow up. So we took the dashboard and kind of blew up a couple of sections for you, and then we showed you that we have kind of symbols. We have an equal sign, means there's no disparity or there's equity. And then when we see inequity, differences that are statistically significant between those two groups, then we put it in a yellow box, and then we also say who it favors. Because in some instances, the historically advantaged population is experiencing the disparity. So we're walking through that conversation as what do we do when we see it, what some people call a reverse disparity, and we've kind of started to label the historically advantaged population, majority population sometimes in our market anyway, experiences the disparity. But in this, so you can see that illustrated here in this graphic.
And then just to focus primarily on racial and ethnic disparities observed in the ED, is that correct? And why?
We of course, we said a moment ago that we do look at this issue of socioeconomic status. We've also looked at data with regard to age and gender, but we're really focusing on the IOM message around unequal treatment being focused specifically around the historic race and ethnicity disparities in our country and certainly in our region. So that makes good sense to everybody in senior leadership and at the board level. So we've kind of just stayed focused on race and ethnicity for this first generation of health equity work, I think. Otherwise, I think the message gets diluted across such a huge healthcare system. So we're trying to keep it really simple for our leadership. In this illustration, then, and what you heard previously, we worked on something, and I'll show you. Go to the line graph, the next slide. We'll show you a trend analysis. So we will take the data that we get and trend it on a quarterly basis, comparing head-to-head the two groups. In this case, it's race, so it's white versus non-white. And what we see here and we're able to establish is a very consistent, very strong message, which you say these look like railroad tracks, and they're parallel, and we're not closing the gap. And we see it happening over 8 quarters. That's a compelling message to say we need to do something about that. Now, if you look at many of our other metrics, you have a lot more variability. Sometimes it comes close together, and sometimes it goes farther apart, but there's not a consistent disparity. And so when our leadership has an opportunity to look at this, they say, well, let's look on the thing that's consistently disparate. And that's helped us a lot get some political traction for doing something. The next slide, which is the bar graph, then enables us to break apart the healthcare system average, which is the blue bar, which is what I showed you in the line graph, was just tracing the system's average. So now we're saying we have a collective delta between race and ethnic disparities across the system. Our system board says, listen, we need to work on that. So then we start to find the hospitals where the problems are. And this particular bar graph then illustrates that below the blue bar are hospitals that are performing worse than the average, and above the blue bar there are hospitals performing better. So there may be some best practices above the blue bar, and there may be some worse practices below, and so we're now at that point of actually having conversations at the hospital level for both the people that are doing well in this particular metric and those that aren't. But at the end of the day, what we want to try to find is what is the lever that we can pull here to move our blue bar back toward less disparity. So in that sense, then, our improvement strategy is just launching this particular fiscal year, and we have a pilot intervention with 2 of our hospitals who've raised their hand, both of which are controlled by the same leadership structure, and both in the ER particularly. And so we've approached them to develop a local intervention team, of which then our department will help facilitate that conversation and work with them through a CQI process with rapid process improvement with regard to particular metrics. We are obviously asking, using some literature, we'll feed them some of the literature to prime the pump, so that they'll start to look at what do they think the levers are. Maybe it is pain control with minorities, or maybe it's just responsiveness questions because we don't have good use of interpretive services or language lines. So we have to fishbone that process of what they think. They're the experts at the local level that see what possibly is causing the problems, and then do some interventional design work with them. But they'll be the ones who actually do the interventions. Our next slide is an illustration of our ambulatory work, and I've placed in this presentation an illustration of a table that we have used recently over the last few months to talk to our physician organization. As I said, it's approximately 500 physicians that are employed in over 100 sites. And so we have been responsible to help them start collecting race, ethnicity, and language data at the point of service in the private clinic, and putting that data into an electronic database, and then extracting that data and cutting their diabetes care management data through the lens of race and ethnicity and payer. In this illustration, what we're showing is that we've identified disparities in the amount of control. And Joe, you had mentioned this in your work at Mass General. We found the same problem that you might have illustrated, but we see this in our private practice. And you can see here among 11 clinics reporting that have been collecting race and ethnicity data and language data, that we have a pretty significant disparity over 12 months, over 4 quarters.
Right. And then, well, why did you choose that indicator, Jim, by way of background there?
Well, we chose the indicator because that's what the physicians were holding themselves accountable for. So we have, the employed physicians have financial risk on quality performance. And so we approached the quality committee of the physician organization and said it's quite possible that your quality performance is created by disparities. And we went then and proposed to them that we collect race, ethnicity, and language data, number one, cut the data, and then reflect back to them to see if there are actually patient subpopulations that possibly are not receiving the quality care that they should. And as you can see here, in some of the illustrations, that's indeed the case. And so we do have opportunities for improving care management, and that then will turn and help the physicians achieve their quality goals, which then ties back into their reimbursement or their pay.
Makes a lot of sense. And what are you planning to do with some of the results of the work so far, Jim?
So recently we approached our quality committee after we found these data. We went back to them and said, I think we have a solution for you. Parallel to this work, we had started a diabetes equity project among our underserved population that are visiting our charity clinics in the community and other work we do. So what we wanted to do was export what we've learned among the underserved clinics or the charity clinics to private practice. And so the way we approached that was we went to the Best Care Committee or the Quality Committee of the physician organization and showed them some data that I've revealed for you in the next slide in the little graphic, and asked that we would pick 4 of their clinics that have a large number of Hispanic patients and see if we could actually demonstrate some improvement within those private practices. So if you'll go to the next slide, what you'll see in that graphic is a line graph over 12 months of what we call the Diabetes Equity Project. It's a funded project from the Merck Foundation that we've been involved with. And what we show in this graph is that when we started the project, that the baseline percent of patients these are all uninsured, low SES patients, the percent that were under control with an A1C measure of less than 7 were around 24%. After 12 months of this intervention, we show that that's improved almost to the benchmark of both Minnesota, the state of Minnesota, as well as the physician organization as a whole. But what was really important in this slide was the two kind of call-out slides, which is that we had achieved that, but there was no statistically significant disparities between race and ethnicity at the 12-month mark. So we're very, very pleased with these early results of this particular project, and so we were ready, if you will, to export it into private practices to see if in fact we could achieve a closing of the gap for private patients that are commercially insured, but also people in historically disadvantaged populations. So finally, I'll just close with this, and we'll take questions. Our conclusion is health equity is extremely important as a value that we share at Baylor, and it's located in our quality performance activities. Health disparities occur, and inequities in access do occur as well. And so we know we have care delivery challenges, and we also have access challenges in our market, and we're working on both. And improving that health equity is just consistent with our mission. We know that best practices exist in Seattle and New Mexico and Boston, and we're ready to go learn from those groups and import that back into our organization. So I want to thank you again, Joe, for hosting this, and I'll stop there.
Fantastic. Thank you so much, Jim, for that wonderful information. Again, I think another example of taking the monitoring piece one step forward, developing interventions and beginning to address them. I think the issue of relating to private practices is also very interesting and unique in many ways, and I think will provide a lot of lessons nationwide. So thanks a bunch for that. Thank you, Susanna, as well as Sarah, for those wonderful presentations. And we are going to now move to our question and answer period. And I want to go ahead and open up the discussion to all speakers for some of the questions we received from the audience. Unfortunately, we won't be able to get to all the questions, but we'll do our best to get to as many as we can. You can submit questions by typing them in the chat box at the lower left-hand corner of your screen, making sure that you specify to whom the question is directed, if anyone in particular, and hit Submit Question. The panelists will try to answer the questions as succinctly as they can so we can get to as many questions as possible. Before we begin with the audience Q&A, I'd like the audience to take a moment to complete the survey that will pop up on your screen momentarily. Please be sure to allow pop-ups for this site if you are prompted. If you need assistance with this, please press *0 on your phone at this time. And while the audience is filling out the survey, I'll go ahead and start the Q&A session. And I just want to go ahead and address a couple of the general questions that were put out, and then go ahead and take some particular questions for our speakers. I'll just mention that there were several questions about collecting additional information as part of our dashboards. Someone asked about collecting information related to disabilities. I think Susanna presented that they are being quite innovative in collecting information about sexual orientation. We also had a question about any consideration being given to collecting socioeconomic status. I'll just mention that here in Massachusetts, we're required through our state healthcare reform to collect not only race and ethnicity and preferred language, but also highest level of education. And we also track SES, but those are primarily SES is primarily done as education as a proxy for SES, along with health insurance status. But I will say that I think it is important for us to think about how we could gradually begin to collect information on all of these characteristics. Certainly, I think the principle of equity applies to any area where there are disparities, and then that could be related to gender, sexual orientation, disability, or other factors. So I would put no limit on the important information we should collect. I think each hospital should focus on the things that are important to their catchment area, roll them in a timely fashion. I think we have several examples here of organizations that have done that. But at the end of the day, my view is that as much as this information can be helpful, useful, and is important and related to equity and disparities, it should be collected. It just may need to be done in a stepwise fashion. Here we talk particularly about race and ethnicity, but that's not to mean that these other key bits of information shouldn't be collected and stratified as well. There was also a question about what kind of training do staff receive who collect race and ethnicity data from patients to ensure that it's accurate. And maybe I'll go ahead and turn that over to Sarah. Sarah, are you interested in, would it be possible for you to answer that question around training that your staff receives on collecting that information?
Sure. I would point people to the HRET toolkit. There's a lot of really helpful information there. There's a slide deck you can use. I think the first step is to have buy-in from the department's leadership that this is part of the job and that it has to be done. And from there to create, when you're presenting how to collect the data, to really create an environment in which staff can express their questions and concerns, and to loop back with them fairly quickly so that they can explore with you the challenges that they're having. So a common challenge here and at other organizations who use self-identified race and ethnicity, for example, if you use the OMB standards, you have, in our region in any case, you have a lot of Hispanic Latino families being confused when they're asked to identify their child's race because they consider their ethnicity to be their race. So to work through, to create an environment in which our registration staff can talk with me about their questions, and also they have a point person, a QA point person in their department who creates tools for them as they're doing their work that she shares with me and are really helpful tools as they run into struggles like that. So I'd say make it a job imperative. This is part of your job. And then also create the place for people to ask for help and give you their input on how it's going.
Great, and that's wonderful. And I want to turn this over to Susanna as well, because there's a question about how do you deal with patient resistance to reporting Reals data, and that kind of ties into this training piece. You want to comment on that?
Sure. Sarah just pointed out one of the issues that we have here very much being a majority minority state and majority Hispanic state, that race and ethnicity can be conflated very quickly. And then when research shows that when given a choice of race, many Hispanics, we use the term Hispanic here in New Mexico, tend to check white. So it gets very confusing very quickly. We are working at improving our training around this, but the fact that we use a self-report form really helps reduce resistance from the participants. We're looking at improving our scripting around helping the frontline staff understand why we're doing this so that can be communicated to the patient.
Okay, thank you very much. Just a point of clarification, somebody sent a question around what do the initials HRET mean. Just to re-mention this again, the Health Research and Educational Trust, who's the educational affiliate of the American Hospital Association, our partner in this web seminar, HRET, as they're known, developed a toolkit on the collection of race and ethnicity data, and that has a lot of information, I think, that addresses many of the issues that we talked about. Susanna, I just have a couple of questions that I think you'll be able to answer fairly quickly. One is, how many staff are in your department to accomplish the work that you do?
One. That would be myself.
Okay, a army of one. All right, and the second.
So far.
And the one person can get a lot done. And the second question here, related to some of the particulars around your organization, is who do you report to in your organization, and is your department part of community relations or human resources or something else?
Thank you, Joe, for the question. I report to our administrator for ambulatory services, who reports directly to the CEO. And the reason for that is that sort of like what Jim mentioned earlier in terms of making certain decisions for political reasons in terms of the outcome, that was a decision for those reasons. What I mean is that my administrator, my director, even though her purview is all of our outpatient services, she is very much a champion. She is very much on board. She is very much passionate and committed to this issue, and because of various shifts in our organizational structure over the last few years, gradually she has found herself overseeing our Native American Health Services Office as well as our our Interpreter Language Services Department. So even though these offices don't just serve ambulatory, she really she's the right person to be overseeing this office and this initiative, and so for now that's where it resides.
Fantastic. Okay. Thank you for that. Jim, a question to you, and you and I over the years have talked a lot about the importance of benchmarking and kind of, where do you begin? And somebody sent in a question that, once you have your patient demographic data, what is the one hospital equity indicator that all hospitals should start with? And maybe one is too few, but can you give some thought to that or some guidance on that issue, general approach?
I think that's a good question, because I think for us it's always been about politics, internal politics around what do we need to be doing. And so it is, at one point in the past, our hospital's executive leadership team was giving a performance-related pay related to quality. Okay, so if that has indeed happened in an organization or that's being considered, then one of the things that we began to think about in our organization is what are those quality metrics that are tied to leadership's executive pay or evaluations, even if there's no pay tied to it. And so that would be number one for us, would be how do our executive team, how does our board and our executive team look at quality now in the general broadest sense? So, for example, core measures are one of those things, and patient satisfaction is another one. And then what we did in the Office of Health Equity is really work very, very hard to say, I'll bet you $1 that the literature is right, that there are disparities, and those historically underserved or disadvantaged populations are probably holding or tethering if you will, tethering down the performance on these quality metrics. And we've begun to win the day with that argument that says, yes, that the data is revealing that in some instances, and that so to make progress on those quality metrics, then they actually do in support, if you will, working on disparities or inequity. So that's kind of how we did it. So core measures, patient satisfaction, obviously readmissions, 30-day readmissions are becoming very important for the very near future for reimbursement purposes. And so you might think of it also through the lens after that would be for reimbursement purposes for the hospital's health and welfare, so that the department can grow, so we can continue to fund, if you will, cost centers inside the organization.
Got it. So you're hitching these to you're hitching your measures to the ongoing movements that drive resources, accreditation, and the like.
Right, that would be number one, and then number two would be then what does the epidemiology say? So we also see that we have an epidemic of diabetes in our community, and so we would say, and then we would also probably have a proactive strategy like in our ambulatory environment, where our private physicians are saying diabetes is extremely important to us because of the epidemic nature of it, and we need some help getting control of this. Well, that revealed some disparities in helping them to get control. We started to show them that there was disparities in historically disadvantaged, and off we go. So I wouldn't just link it to performance, pay for performance, but how important that is in this tight environment. So we'd be remiss not to say that.
Yeah, and I think that's a nice framework for this individual and this organization to think about. And some of this may be tailored to the local environment, local need, but that's a nice set of things to be considering. Jim, I got one more question for you here, and this goes for the other speakers as well, but I wanted to begin with you. Have you shared any of this data with community organizations that focus, that are minority community-based organizations, or that focus on any of these issues, or worked on with any community-based organizations on improving equity?
Yeah, so our large initiative is in the ambulatory space. Our longest running initiative is in the ambulatory space, or in the non-hospital space, and that is regarding access creation for minority populations, and then of course this diabetes equity project. So we've focused in those particular spaces. So we work with those entities that have stepped up and said we would like to work with Baylor and other entities around improving access, so creating access capacity, and then, most importantly, is to make sure those entities then are using normal metrics. For example, are they achieving adult preventive services at the appropriate rate, if you will, at a standard rate, and if not, and there is a gap, and we know that, then how do we change that? How do we close those gaps? And the same with diabetes care management. Interesting, what we've discovered in this diabetes equity project is that if with allocation of discrete resources, we can actually beat, if you will, or compete head-to-head with private practices with achieving equity. And so we'd like to be these organizations to actually to kind of be a center of excellence around reducing health disparities.
Thank you. That's very helpful. Sarah, I have a couple of questions here for you. One is, do you collect the child's and/or parents' preferred language, as these may be different? Do you know?
We ask, what is the family's preferred language to receive their child's care?
Got it.
And typically, that is the parent's language need that is identified. Most of the children that we serve end up being bilingual. We do have some refugee children who end up needing an interpreter for themselves. We ask a second question. We really ask the question twice. We also ask, will anyone in the family need an interpreter? So we have two fields.
Got it.
And, largely it's the parent, but we're really trying to get at all family members' needs, especially because oftentimes mom and dad have different levels of English proficiency.
Got it. Another question is, how do your patient navigators differ from your case managers and social workers?
That's a great question. We look at our patient navigators as a bridge to existing hospital services and a bridge to the expertise we have at the hospital. So our social workers are master's trained, very experienced in what they do, and the patient navigators share with families what the social worker's role is and help build families' trust with the social worker. The social worker and the navigator do have a lot of overlap in responsibilities, and we let the social worker be driving the bus. How can the navigator help them accomplish a lot of work that needs to be done? Likewise, we have nurse care coordinators, and the navigators are linking families to those nurses and helping them trust them.
Got it. Follow-up to that, any cost-effectiveness research done on the navigators? Have you been able to assess their cost-effectiveness?
We do have an external evaluator that is doing a cost-effectiveness assessment. I can't give you the answer at the moment, but I can tell you a couple examples. For Somali patients who do not have a patient navigator, their missed appointment rate is 18%. And Somali patients who do have a patient navigator, their missed appointment rate is 12%. For Spanish speakers without a navigator, 8% of appointments are missed. Those with a navigator, 5% of their appointments are missed, which is actually less than that of the English-speaking Medicaid population. So our hospital's been pretty encouraged by that. We also have higher rates of completed referrals. So if a PCP sends a referral to us, those with navigators are much more likely to complete, and much higher provider and patient satisfaction. We're looking at length of stay, but frankly, I'm not particularly hopeful that it's going to be any different.
Got it. And I have one last question before I go back to Susanna. Can you give some examples of pushback that you faced with your leadership and registration staff, Sarah? Prior to or in response to that pushback, how did you identify and utilize champions?
I honestly have to say that we have not had a lack from our leadership. Our leadership has been incredibly supportive at the hospital. I would say initially with registration staff, when we started collecting race, ethnicity, and language data, registration staff who had been here for a long time were more resistant than newer staff, and as turnover has occurred in the department, the registration staff are now on board because they came here and this is part of their job when they came here. In terms of champions within the hospital, I would encourage people who are interested in taking on this work to position someone in the department or someone involved in the work who has a pretty long history at the hospital. I was here for several years before I started this work, and so I had relationships throughout the hospital, and I already kind of knew who I would go to and work with, so that's been really helpful to our center.
Great. Susanna, question for you, and I think also, Jim and Sarah may be able to comment on this. You have a couple of questions that ask, do you plan to break out your ethnicity into more granular categories? What do you see as the benefit of collecting granular data versus not? And then, related to that, the question is related to white race. Why for health evaluation is white race not divided into smaller groups like by country of origin? For example, health needs of a new immigrant from Russia might be different than Italians who've been here several generations. So I'll let you begin with that, Susanna, and then maybe Sarah, you could have a comment. I know because you mentioned Russian immigrants in some of your work. So Susanna, you want to go ahead and then we'll pass it on?
Absolutely. The OMB as well as HRET and other bodies very much encourage that granular data be collected, but that the granular data has to be relevant to the area in question. So I'm going to go ahead and re-show folks the slide of our intake form, and you'll notice that, again, this is going through revision, but we've got several different categories for language, which reflect our major demographic groups here. And particularly with regards to Native American tribal affiliation, that is also partly due to agreements that our organization has with IHS and local governing bodies, especially of our All Indian Pueblo Council. So yes, we do collect granular data. And in terms of white ethnicity, in New Mexico, we really don't have very much recent immigrant white patients. We do have a small population of Russian speakers, but after Spanish, Vietnamese, and Navajo, our most frequent languages after that are Arabic and Swahili. So we don't really, not to say that they don't exist because they do, but in terms of really identifying the disparities of having any meeting here locally, we don't find that that's quite as relevant.
Got it. A couple of questions. Actually, Sarah, I wanted you to comment on that if you could as well.
Yeah. We do find the OMB categories too limiting in terms of our Asian population. There's a lot of Asian diversity here in our region, and we can't tease that out with the way we currently collect it. Our language collection does help us, for example, identify the Russian speaking population, as you asked about, Joe. Frankly, and this is for people on the call to consider, we're very interested in following the Institute of Medicine's recommendations to collect more granular ethnicity but we're not doing it right now because we want our Joint Commission audit for communication standards to pass with flying colors next year. So I don't want to switch with my registration staff what they're doing before the Joint Commission is measuring us on it.
Okay. Jim, I want to end with you. I just have a couple of quickies here. One is, what do you think about the necessity of insurers/payers to collect, monitor, and develop interventions around racial and ethnic data and disparities?
So, I think it's vital that at all points along the way, this message of health disparity start to get addressed in some way. And I know that there are multiple payers right now that are looking at this and trying to reflect their activity in this space so that they not only can drive down the cost of doing business while at the same time improving the quality that they're able to deliver for their customers. So I think it's a very savvy market strategy for a payer. That'd be so that you can approach the diversifying workforce in America. It would just make sense that you would have a strong equity approach in your healthcare payer community. So I think it's a positive business strategy. And
this is probably a couple of liner here for you, Jim. Somebody wanted you to explain, just clarify. You were using the term historically disadvantaged as opposed to just disadvantaged. Can you give just a very brief thumbnail on that?
Again, a lot of the language we choose to use here in our market is for our local customers, which are our leadership and our board. So when I say disadvantaged, they might ask me a question, and I just use the adjective historically in front of it, and I think it communicates a lot more effectively to them about what we're trying to talk about here in the local market.
Got it.
There is a lot of history here in Dallas and in the South around that, and there's a current activity around that, and as everybody in the country knows, and so we're tying into that history.
That's very helpful. I want to just mention one thing. There's a question about healthcare reform and how healthcare reform would be helpful or limit this work. And I'll just say that healthcare reform is the first time in the last really since the release of the Institute of Medicine Report on Equal Treatment that there's been any federal legislation that has disparities-related provisions. Now, I encourage people to go to our website, which is listed here, www.mghdisparities-solutions.org. We've done a web seminar on the impact of healthcare reform on disparities, and you'll be able to get more information there. We are at the end of our time. It's now 90 minutes into our program, and I want to thank everyone for being on, and particularly thank our speakers today, Susanna Rinderle from the University of New Mexico Hospitals, Sarah Rafton from Seattle Children's Hospital, and Dr. Jim Walton, our good friend from Baylor Healthcare Systems. Really, we appreciate the work you're doing, your passion, your commitment, and thank you so much for sharing your expertise with our audience. I also want to sincerely thank the American Hospital Association and the Health Research and Educational Trust, our partners here with this web seminar, for their support and their continued leadership, and we look forward to partnering with them, continuing to partner with them in the future. To find out more about our Disparities Leadership Program, please visit our website at www.mghdisparities-solutions.org. Again, an archive of today's web seminar along with a copy of the slides will be available on our websites in 2 weeks. Again, our website, mghdisparities-solutions.org. You could also view the archives of our previous web seminars on our resources page, and HRET's website, again, is www.hpoe.org. A plug here for our Disparities Leadership Program. These were all alumni of our Disparities Leadership Program who we continue to work with. 4 years of this program now, a wonderful group of organizations around the country who are committed to this work. If you're interested in joining, please go to our website so you can learn more about that. Please complete the survey on your screen. Your feedback is incredibly important to us. It will help us evaluate the web seminars that we do. If you'd like to sign up for our mailing list to receive information on future web seminars, other helpful tools for reducing disparities, please visit our homepage and click on the Sign Up link to register. If you have additional feedback around future web seminar topics, we would greatly appreciate that. From our whole team here, as well as our presenters, the Disparities Solutions Center, HRET, American Hospital Association, we want to thank you again for joining us and wish you all a wonderful day. Thank you.